Hey, I'm Bhagirathbhai Dholaria. I'm from Vanderbilit University Medical Center in Nashville, Tennessee. I'm one of the stem cell transplant and CAR-T physician. I would like to thank the organizing committee for this conference for inviting me for giving this talk. I'll be speaking over the next 20 minutes about the role of CAR-T cell therapy or chimeric antigen receptor T cell therapy in various hematological malignancies. Trying to give you some updated data from the recent clinical trials and give some important practice pearls at the end of our meeting, but how to manage these patients in the day-to-day clinic and in the hospital setting. These are my disclosures. None of them are relevant necessarily to today's discussion, except I do receive some research funding from some of these companies who also makes CAR-T cell therapies. This will be the overview of our talk today. We'll start with some basics of CAR-T, going over the role of CAR-T cell therapy in diffuse large B-cell lymphoma and B-cell acute lymphoblastic lymphoma, and end our discussion with some practice pearls and some real-life example of how to manage the toxicities of CAR-T cell therapies. I will not be talking about CAR-T cell therapy in multiple myeloma, since it will be covered hopefully by my colleague, Dr. Saji Kumar, later in the day. So we'll start with a case, a 68-year-old patient. This was a patient of ours at Vanderbilt who was diagnosed with high-grade B-cell lymphoma. It was a quite advanced disease, and biopsy confirmed that it was a large B-cell lymphoma. So as of now, the standard of care for newly diagnosed large B-cell lymphoma remains combination chemoimmunotherapy with rituximab with a CHOP chemotherapy backbone. So this gentleman received the 6 cycles of chemotherapy, had initial response, achieved a complete remission, but unfortunately he relapsed within the 6 months of therapy. So you can see here his original PET CT scan at diagnosis on the left side, and then unfortunately at the time of relapse he had a widespread metastatic disease involvement in the multiple lymph node regions throughout his body. So how you would manage this patient in your practice, where this gentleman had initial response to R-CHOP chemotherapy, but unfortunately had an early disease relapse within 1 year after completion of frontline therapy. So as of a few years ago, before the CAR-T cell become part of our routine practice, this how we would have managed these patients, where patient would receive some salvage chemotherapy, ideally some platinum-based combination of chemoimmunotherapy, such as rituximab with ifosfamide-based regimen, or our GEMOX, or our DHAP. And if the patient has chemosensitive disease, then we would take this individual for high-dose therapy and autologous stem cell transplant. If the patient does not respond to salvage therapy, then you try some different things and see if you can get them to some type of disease control. However, we know from historical data that only a small minority of the patients who had early relapse after R-CHOP chemotherapy are actually able to get to the stem cell transplant. Though the transplant outcomes are still reasonable, which cures roughly half of the patient, only a fraction of patients will make it to the transplant, because many of the time these patients don't even respond to the chemotherapy we administer after initial R-CHOP failure. So the role of transplant was established a while ago. Now, this is an old paper from 1995, where conventional treatment was compared to the autologous stem cell transplant and showed the transplant recipient had improvement in overall survival and long term. So transplant does cure patients with relapsed diffuse large B-cell lymphoma. However, if you look at specifically the group of patients who had primary R-CHOP refractory disease, or had failed 2 or more lines of therapy, or had early relapse after stem cell transplant, their outcomes remains quite dismal. So this is a meta-analysis of SCHOLAR-1 database, and you can see it's over 600 patients were analyzed, and the response to the next line of therapy was only 26%. So only 1 in 4 patients actually responded to any treatment, which given in the median overall survival was slightly over 6 months. So this certainly there is a room for improvement here, and this is prior to CAR-T cell therapy. So this is our reference point. This is where we're starting from. So why CAR-T? Well, as we earlier learned, the relapsed lymphoma carries extremely poor prognosis, and many of these patients don't even make it to transplant because of refractory disease. Many of these patients are older, had multiple comorbidities, so the transplant programs may decline these patients to give high-dose chemotherapy because of the risk of organ toxicity and the transplant-related mortality risk. So CAR T-cell therapy offers new hope to this patient population. Now, CAR T therapy is fundamentally different from what other cancer therapies we have available, such as chemotherapy or even immunotherapy based on monoclonal antibodies. These therapies are derived from patients' own T cell, which are genetically modified, and it allows us to kind of combine the best of both worlds, so the B cell specific immunity as well as the direct cytotoxicity of the T cell. And it can overcome the immune tolerance to many of these patients. And this CAR T cell therapy can engage with the tumor cell independent of any antigen presenting cell or MHC HLA presenting. So these cells are directly specifically activated to target the tumor cells and kill it. So these are some basics about how the TCR or and the CAR T construct differs from each other. So this on the left side is a T cell receptor complex here, where you have, so your alpha beta chain with the CD3 molecules, and the CAR T construct or chimeric antigen receptor construct is basically a stripped down version of this TCR complex, where this DNA sequence this is an artificial molecule made in a lab, combining the component of the T cell receptor here, which is a transmembrane intracellular component, fused with a SCFV from the very specific monoclonal antibodies. So in our case with the lymphoma, most CAR T cell therapy currently available in the markets target CD19, which is universally expressed in most high-grade B-cell lymphoma patients. So this extracellular domain identified the tumor-associated proteins, which leads to activation of this CAR construct and intracellular activation, signal transduction, and activation of this CAR cell in the patient's body, which leads to direct tumor killing. Now, the first generation of CARs had a very dismal tumor activity, mainly because they didn't last long in vivo, they didn't expand that well, and they suffered from this limitations of the activity in vivo. However, when the co-stimulatory molecules such as CD28 and 41BB were added to the first generation CAR construct, these second generation CARs, which we are using right now in the clinic, such as Axi-cell and Tisa-cell and Lyso-cell, these second generation CARs are lasting long. They expand very well in vivo and had a much better efficacy compared to the first generation CAR, although it comes at an expense of higher toxicity, such as cytokine release syndrome and neurotoxicity. We are also now currently studying in phase 1 and 2 studies of third generation, now even fourth and fifth generation of CARs with some additional immunomodulatory molecules kind of combined with the CAR construct. So this is kind of basic schema of how CARs are manufactured. So the patients undergo leukocyte apheresis, and these PBMCs are shipped over to a company, or if you have an in-house CAR manufacturing, then you send it to the lab, and these T cells are then activated outside patient's body, and then this CAR gene is inserted into this patient's T cell to make the CAR cells, which are then subsequently infused intravenously into the patient. There are multiple gene editing technologies right now available. The most common one is viral vector, where either gamma retroviral or lentiviral vectors transmit the CAR construct from to the patient's gene, and then it leads to CAR manufacturing inside the cells. Moving on to the currently available clinical data. So the ZUMA-1 was the first trial showing the excellent outcome in a patient with relapsed or refractory diffuse large B-cell lymphoma. And this patient received CD19-directed autologous CAR T-cell therapy known as Axi-cell, or brand name Yescarta. And we can see here, this is a long-term outcome of the ZUMA-1 cohort, and the responses were quite durable with very few relapses beyond 6 months from the initial CAR infusion without any additional therapy. So we are actually curing roughly 40%, 40 to 35% of the patients with a highly refractory disease, and compared this outcome to the SCHOLAR-1 data, which I showed earlier, where less than 20% of the patients were surviving beyond 6 months. Similarly, the TCell is another FDA-approved CAR T-cell against CD19 directed with a comparable outcome. And this is a lysocell data from the Transcend study, which also enrolled a patient with a highly refractory diffuse large B-cell lymphoma, showing excellent long-term durable remissions. So back to our patients. These patients received CAR T-cell therapy, in this case, exa-cel, in March of 2016. Had some side effects from this therapy, cytokine release syndrome and some neurotoxicity, spent some time in ICU, but overall, he tolerated therapy all right and came out, resolved all the toxicities after week 3. And then this is his PET scan response. And you can see here, pretty rapid and dramatic shrinkage of all his tumor areas. And he achieved a complete radiological remission 3 months after the CAR T-cell infusion. This patient is still being followed in our long-term CAR T survivorship clinic, and now it's almost 2 years. So they're still doing quite well and still in remission. So this patient is cured now. Now, what about the CAR Ts in earlier lines of therapy who had a diffuse large B-cell lymphoma? So the ZUMA-7 of the trial, and Vanderbilit participated in this study where patients with early relapse diffuse large B-cell lymphoma patients were randomized to receive a salvage therapy followed by an autologous transplant versus going straight to CAR T-cell therapy with exa-cel. And these patients showed that patients who received exa-cel in a second-line therapy, especially among the individual with primary refractory disease or early relapse after R-CHOP within a year, had actually much superior event-free survival compared to individuals who went on to receive a second-line salvage chemotherapy followed by autologous stem cell transplant. In fact, only a small fraction of the patients were able to receive autologous stem cell transplant because most of them did not respond to second-line therapy and were switched over to the Yescarta arm. And that's why there was no overall survival difference in this study. However, that was mostly because of the effective crossover, where patients, once they did not respond to the second-line salvage therapy, they end up receiving the CAR T-cell therapy and went on to achieve a deep remission. The CAR T-cell therapy was also associated with a better quality of life. So that has been approved now by FDA in a second-line setting with patients who had early relapse after R-CHOP. Around the same time, 2 other trials were also presented using the TCell and lysocell, among which we saw there was some difference in the inclusion criteria as well as the overall schema of the studies. But what we saw was the lysocell had a very comparable responses like an exa-cel, where patients who receive a second-line lysocell had an improved median event-free survival compared to chemo followed by an autologous transplant. However, the study, Belinda study, which uses the TCell, was a negative trial where there was no difference in the median event-free survival. So currently, we have 2 CAR T-cell therapy in a second line for relapsed diffuse large B-cell lymphoma, exa-cel and lysocell. So as of 2022, with this new approval of CAR T-cell therapy, what we have is individual with relapsed diffuse large B-cell lymphoma. If the relapse happens within the first 1 year of R-CHOP, or they're not eligible for transplant, or had a primary R-CHOP refractory disease, we should take this patient straight to exa-cel or lysocell. And if you have patients who had a late relapse, then the standard of care still remains salvage therapy followed by an autologous transplant as long as you have a chemosensitive disease. If you fail CAR T-cell therapy or stem cell transplant, subsequently patients need additional salvage therapy, and a small minority of these patients might be a candidate for an allogeneic transplant. Moving on to a different disease, again, high-risk diffuse B-cell lymphoblastic leukemia. These patients, if they're not cured with upfront therapy, many of them do not survive, and the response to salvage therapies are extremely poor. So Eliana trial used the T-cell cells. So previously we learned in the high-grade B-cell lymphoma, this drug is approved. Again, the earlier use of this CAR T-cell therapy was actually in a pediatric B-cell lymphoblastic leukemia. And here, the phase 2 study showed that individuals who did receive the T-cell cell for relapsed refractory B-cell lymphoma leukemia had an excellent complete remission rates and with acceptable toxicity. However, a good majority of these patients do experience the cytokine release syndrome and neurotoxicity, but the long-term overall survival was at 70%, showing that these patients can be cured with just a single infusion of the T-cell, which led to FDA approval. And these patients, the Emily Whitehead is a famous patient. She was the first patient in the world received the T-cell infusion in the phase 1 protocol at UPenn. She's over 10 years out now and still disease-free. She was also one of the first patients who received the tocilizumab, the interleukin-6 receptor blocker, for the treatment of cytokine release syndrome. In adult, another CAR-T product, KTEX-19, now known as Tecartus, was studied and showing similarly excellent complete remission rates of 71% in highly refractory B-cell lymphoblastic leukemia. Here, the grade 3 or more CRS was 24%, and ICANS or neurotoxicity was around 25%. What about the toxicity management? These treatments work very well, but they also come at the expense of super activated CAR T cells secreting a lot of cytokines in the blood, and they also can cross blood-brain barrier and cause neurotoxicity. These treatments related toxicities are generally seen within first 7 to 14 days after the CAR T cell infusion in majority of the cases. And most cases, these toxicities resolve nearly completely by end of week 3 or week 4 in most cases. Cytokine release syndrome being one of the most common side effects seen in over 80% of the patients who receive the CAR T cell therapy. And the treatment commonly used for this is initially for the just the fever, which is a grade 1 cytokine release syndrome, is Tylenol and fever management with some antibiotics and fluid. But for the persistent grade 1 or the grade 2 or more cytokine release syndrome, where you have low blood pressure requiring constant IV fluid or IV pressors, or increasing oxygen requirement, these patients would greatly benefit from doses of tocilizumab, which is interleukin-6 receptor inhibitor, which can safely reverse the CRS in majority of the patients. Patients who had tocilizumab refractory cytokine release syndrome do not have that good of an outcome, and we're still trying to figure out how to manage this patient. We treat them with high-dose steroid. Jakafi has shown some early responses in anakinra, which is interleukin 2 receptor inhibitor, IL-2 receptor blocker, also has shown some good responses. The neurotoxicity is another common side effects commonly managed with steroids. In some cases, anakinra, and in refractory cases, chemotherapy such as etoposide and cyclophosphamide. We have also used Jakafi in some of the cases with some success. This is an MRI showing some early changes associated with neurotoxicity. In a highly refractory CRS, we see some changes in the bone marrow and also some organ toxicity, which can qualify as a HLH or macrophage activation syndrome. And these patients should be treated in ICU setting in specialized centers with high doses of steroid as well as sometimes chemotherapy. Late cytopenia is quite common. Actually, over a third of the patients who receive CAR T cell therapy has kind of lingering anemia, thrombocytopenia, and neutropenia. But over time, most of these patients recover their bone marrow really well. But occasionally, you have to support them with intermittent GCSF, some growth factor support, some transfusions here and there. Certainly, if the cytopenia persists and get worse, it's important that we do bone marrow biopsy to rule out any secondary myeloid malignancies such as therapy-related MDS or AML in this patient. Late B-cell aplasia, it's quite frequent, especially patients who receive the T-cell, and they are profoundly hypogamma globulinic for a long, long time. And they are susceptible for some atypical infection, late bacterial infection, fungal infection. We have seen some cases with late aspergillus in the lung. So they should be receiving the regular IVIGs as well as prophylactic antibiotics. There was a study done at Vanderbilt and multiple other centers where we used prophylactic steroids in the first 3 days after the CAR T cell infusion and showed excellent reduction in the risk of high-grade CRS and neurotoxicity. So at our center, at least, all patients who receive exa-cel do receive 3 days of dexamethasone 10 milligrams with quite good outcome. And we actually doing now CAR T cell therapy completely outpatient in our outpatient transplant unit where the patients get the fludarabine and cyclophosphamide lymphodepletion in the clinic, followed by CAR T-cell infusion, and we use the telehealth-based equipment to monitor them at home. We have to be careful when a patient is being evaluated for CAR T-cell therapy, make sure that currently it's taking anywhere from 3 weeks to 8 weeks to manufacture CAR T, and sometimes these patients end up requiring some bridging therapy to control the disease, to make sure they don't disease progress while we're waiting for CAR T to get manufactured. And these patients need to have adequate organ functions to make sure they can get through the lymphodepletion and early toxicities we commonly see with the CAR T-cell therapy. There are also issues with insurance coverage and the social support, which sometimes leads to access issues. So in conclusion, CAR T-cell therapy is an exciting development. It's been increasingly used in different types of high-grade B-cell lymphoma, but also the indolent lymphoma and mantle cell lymphoma and B-cell lymphoblastic leukemia. Think about CAR T-cell therapy in pretty much any patients with hematological malignancy, either in a commercial or in a trial setting. The current toxicity and the logistical challenges do face this barrier for our patients. However, with the novel anti-cytokine therapies and increasing recognition by the insurance company about the importance of this therapy, it is being easier to access this treatment. With that, I would like to conclude my talk. This is my contact information. So anybody has any questions, feel free to send me a message or email. Thank you. Bye-bye.